Welcome to Joint Effort with Des Moines orthopedic surgeons. This podcast covers the pain and injuries that are associated with muscles, ligaments, and joints.
Hi, I'm Barron Bremner, and today on Joint Effort, I'm pleased to have Dr. Tom Dulaney with me. Thanks for coming in.
No problem, Barron.
Dr. Dulaney has been with DMOS for a long time. I think, were you 17 years in Carroll, Iowa, is that right? Before you came down to join us here at the mothership or the bigger?
Yes, I was permanent satellite in Carroll.
Yeah, and you did a lot of great work up in that neck of the woods. It's my understanding you have a couple sons down here in Des Moines and maybe your brothers down here too?
Yep.
Okay.
Basically my whole family's down here.
Great. So moved to be closer to them. I imagine you miss the small town atmosphere, a little bit of Carroll.
Oh, we love Carroll. It was a great place to raise our kids, and it's a great community.
Yeah. You're kind of like me. You do a lot of different things. You enjoy doing a lot of different types of surgeries, right?
Yep.
What are kind of your specialties or things that you really enjoy taking care of in orthopedics?
I do. Being in Carroll, population skews just slightly older. Did a lot of total hips, total knees.
Mm-hmm.
Did a fair amount of sports medicine, and a lot of trauma, a lot of community trauma.
Sure. Just took care of whatever they needed up there. Can you tell me a little bit and tell our listeners a little bit about your background, kind of where you grew up and high school even back that far?
I grew up basically here in Des Moines. Went to Valley, graduated there a long time ago, and then went to University of Iowa for undergrad, did my med school there, and then did a residency out in Akron, Ohio.
Okay. And that out in Akron, that was at SUMA. It's a smaller program in a private practice area. I think, did Dr. Vidito do that too?
Yeah.
Yeah, I interviewed out there. It was a great program, really hard workers. You guys saw a lot of cases there.
It is. It's a very busy place.
Yeah. One time I was playing tennis, and I noticed that you were playing next to me on a court, but you didn't say anything. You were kind of standoffish. But then I found out later that was your brother, right?
Yes.
You have a twin brother, identical twin?
Or was it identical twin brother.
Okay, all right. Did you guys have any kind of weird stuff going on when you were growing up where you'd, dress, switch your clothes, or do anything crazy to trick your girlfriends or parents?
Nothing too crazy.
Okay.
No. He still lives here in Des Moines also, and we're still quite close.
I bet. So your favorite surgeries are basically, some sports surgeries and then total hip and knee replacements. Is that about?
Yeah, I do a pretty big gamut. In Carroll, I did quite a bit of upper extremity surgery, carpal tunnels and wrist fractures. And down here, it tends to go to the hand surgeons.
But still enjoy those.
Yeah, I like doing a little bit of everything.
Yeah. Well, today I want to talk about, although you're not a specialist in just doing fractures, of course, you've had a lot of exposure to them and a lot of exposure to the patients who are a little bit older in our practices who might have some softer bones, things like that. And so I wanted to talk about some common fractures that we see in our practices and some that we call fragility fractures or, osteoporotic fractures. So could you tell me what your kind of working definition or definition of fragility fractures is?
I think the general definition is, a fracture that happens from a standing height or sitting height. So, an injury that, most people with normal bones would withstand and not break.
Right. So, not a car accident or something like that, but if you break an arm from, like you said, you trip in the garden and fall and shatter your humerus, then...
Right.
And why would we call them fragility fractures?
Generally because it's based more on the poor quality of their bone.
Yeah.
The bone is weakening and is easier to break.
Are there certain things that people should look out for, like that they might be at risk for osteoporosis or soft bones, where they might be at risk for these fractures? Certain genetic factors or sex or age or things like that?
Certainly it's something that predominates in postmenopausal women. But it can occur, there's certain medical conditions that can make it happen at any age. There's medications like steroids and things like that you can take and get osteoporosis at a very young age.
So like pills of prednisone and stuff like that?
Correct. Yep. And certainly more common in women. It's certainly going to be more common in white women as opposed to African Americans. Asians are actually fairly at high risk also. But generally, the older you get, the more likely you are to become osteoporotic.
One thing I like to sometimes ask my patients about is if they've had like their mother or father with a hip fracture, or a fragility fracture. I think that can make them at higher risk too if they've got a first-degree family member who's broken something like that. How about, I seem to harp on this all the time, but how about tobacco? Does that help or hinder?
Alcohol, tobacco, both bad things.
Yeah.
For bone.
Not only for making them soft, but also for getting them to heal, right?
Yep.
Yeah. We aren't really osteoporosis doctors. We deal with the consequences of it, and it is in our wheelhouse to help counsel people on it. But what kind of doctors do typically treat osteoporosis if somebody wants to go figure out if they've got osteoporosis or they're worried about it before a fracture?
Most of the internal medicine doctors will take care of those issues. Most of the treatments are medically sophisticated enough that you probably want someone besides your bone surgeon taking care of that for you.
Your bone carpenter?
Yes.
Yeah. So that's a good idea, and that's one thing I think that some people neglect doing is talking to their internal medicine or primary care doctor about their bone health even after suffering a break like this, because if you do break one bone, you're at higher risk for breaking other bones later on.
Yeah. Insufficiency fractures, first 2 years, there's a very high risk of having a second one.
So today, can you tell me kind of some of the areas on the body that are maybe prone to, because not every bone breaks from an insufficiency fracture. Can you tell me some of the areas that are problems, and then we'll go into those in more detail later?
Well, I think the classic locations are your distal radius, your hip, spine, and proximal humerus. I think those are the main ones. Although I think we certainly see tibial plateau fractures and ankle fractures and things like that are fragility related. But I think the hip and spine and wrist are the three big ones.
So on a proximal humerus fracture, which is really a shoulder fracture, it might be a woman or someone who falls from a standing height, jams her elbow in, and it breaks the top of her arm bone near the shoulder. We call proximal because it's up at the top part of that humerus bone. In your practice, how many of those go on to need surgery? Are there other ways to treat it?
I would say the way I've treated these has changed rather dramatically in the 20 years I've been practicing. I mean, this is something we used to treat with plates and screws and fairly aggressively. I would say now I treat 99% of proximal humerus fractures conservatively.
Conservatively meaning without surgery.
Meaning without surgery. And I think the advantage is now we have the ability to replace shoulders so much better than we could 20 years ago. That for the patients that do heal in a way that they don't like their shoulder function, they do very well with shoulder replacement. And it's much easier to perform that procedure if somebody hasn't been in there putting screws and plates and a bunch of hardware in there for them to take out.
It's the soft bone is hard to get screws to hold into and things like that, so it can be a challenging surgery. And like you said, I think a lot of literature has come out lately, or at least alluded to, that where we find that we could try a lot of different things surgically, and sometimes they're no better in a study than when we just left it alone. Boy, I have a hard time when people come in, though. They're like in that 3 days after they break it, and they're like, you got to do something about this. It's killing me, and it's a really hard conversation to have that, it's going to hurt, but if I did surgery on it, it's not going to immediately solve your pain either. So that's
and
a tough
it is a
conversation.
fairly painful fracture,
Yeah,
too.
very painful. So typically you might put them into a sling or an immobilizer for how many weeks, you think?
Yeah, I treat people with a sling for about a month.
Okay.
And have them just do some really simple pendulums on their own. I see them back in a month, and if they're starting to lay down some bone and healing, then we progress them into formal physical therapy. Usually do that for 4 to 6 weeks.
Okay.
And then I kind of evaluate them and see how they're feeling, and if they're functional. I mean, certainly most people with proximal humerus fractures don't completely return to normal shoulder function.
Right.
But if it's satisfactory and they can do all their activities daily living and they're not having much pain, then most of those patients we can continue to treat without surgery.
Yeah, great. How about, we talked about the upper arm. You said the distal radius, which is the wrist down near the small bones in the wrist. So it's the end of the forearm, basically. We see that pretty often. What's the mechanism for how somebody would break the end of their wrist like that?
Most people are generally falling on an outstretched hand and basically just hyperextend their wrist and and crack it backwards is kind of the classic caulis fracture.
Yeah, it could be a pretty dramatic looking injury, right?
And interestingly, caulis fractures, I've had the exact opposite evolution in how I've treated them, in that when I trained, we fixed hardly any of these fractures. We reduced all of them, treated them with casts, and now the techniques have gotten so much better, we fix the vast majority of them, and they do much better with surgery.
Right. Yeah, because the options back, and even now, are putting it back in place, like, having a person asleep or injecting them, thunking it back into place, and then you have to do a cast for about 6 weeks. And sometimes that works, but then you have to follow it every week, basically, to make sure it doesn't shift, and a certain percentage of those wrist breaks shift, and then you're trying to deal with a halfway healed fracture. So,
and they're stiff, and they struggle a lot more, whereas if you can fix these things and get them moving their wrist earlier, they just do a lot better.
Tell us about the locked technology that made that possible, because we didn't always have good implants for that.
The problem with wrist fractures was always the hardware. That it breaks close enough to your wrist joint that you really don't have the ability to put a lot of hardware in the distal aspect of the fracture. And now they've come up with a design where the screws can actually lock into the plate. It makes it a much more stable construct, and it works a lot better.
It's a lot easier to get it anatomic, because you don't have much room for error in the wrist if you want to have your full range of motion. And then, so if you see somebody, I don't know how you deal with this. If somebody comes in with one of those two fractures and they're not on a calcium or a vitamin D or something like that, what do you say to them when you're, a month into it or a couple weeks into it or something?
I think it is important, and it's something that even I, don't always dwell on with patients, but I think it is important at least inform them that their fractures probably occurred because of poor bone, and so they probably should follow up with somebody about their bone health if they haven't already. Some of the patients are already well aware that they're osteoporotic.
Right. Yeah, I 100% agree that it's important to bring that up. And if they smoke, it's important to bring up that they need to quit smoking for multiple reasons, but we're kind of selfish. We want them to quit smoking for the bone health. Hip fractures are it's a pretty generic term. We call it a hip fracture, and you might hear your grandma's friend got a hip fracture, but there's a ton of different kinds of hip fractures, and they don't all involve the hip joint. Some of them are the thigh bone, and some of them are the pelvis. Can you tell us about some of those different fractures, where they are? And
the hip joint is basically a ball and socket joint, and I would say the majority of the fractures tend to occur inside the joint, either involving the ball snapping off or cracking. If the ball snaps off, then generally it's treated with a joint replacement, and a lot of that depends on the age and activity level of the patient. If they're an older patient without much arthritis, then generally we treat them with a partial hip replacement, because it's safer, quicker procedure.
What's that mean, the partial?
It means basically just replacing the ball part of the hip.
Okay, so if they broke off their ball and it's 50 millimeters big, you put in a ball that's 50 millimeters big.
Exactly.
But you leave their socket alone.
Right. Whereas if they're a younger, more active patient, generally we treat them with hip replacement, because that metal ball that we replace with time does wear away the socket. And so in a very active patient that's 70 years old and suffers a femoral neck fracture, you can do a partial replacement on them, and they will do well. But if you see that patient at 10 years, a lot of them are going to need to be converted to a hip replacement that could have just been done to start with.
They might get some groin pain and something like that.
Exactly.
So the ball snaps off is what you're talking about. Why can't you just, put some a plate and screws or something on it? Or
if it's non-displaced or impacted, you can fix it with screws. The trouble with displacement is it alters the blood supply to the ball. And so even though you could go in and screw it back together, that bone essentially has no blood supply. And so with time it dies and doesn't do as well.
I think not all of us, but most of us who feel really comfortable with joint replacements are moving away from putting screws into the head for these type of fractures. And I found that even if you get it to heal, which is only like 80% of the time, they're in a shortened position, their biomechanics are off, they're unhappy with it even then. So it's a lot quicker healing process for a partial or a full hip replacement.
A lot of it I think depends on the patient too. There are some patients that I'll pin. But for a patient that really wants to get back to hardcore walking, that really wants to be a good community ambulator, joint replacement works well.
If you break it down a little bit lower, we call it the intertrochanteric region. It's where a lot of muscles are attached. There's a couple bumps on the femur. So we're not down in the shaft, but we're not up in the ball. That's a pretty common break in the people's in their 70s and 80s and 90s even. What do you do for that sort of an injury?
Traditionally, when I trained, we tended to treat them with plates and screws. We had a large screw that would go up into the femoral head and a little plate that we'd put on the side that would hold it in place. Now they've come up with some devices that you can actually use intramedullary, which is nice. You basically put a very small rod inside their femur. It takes much smaller incisions, less dissection to put in. So the surgery is smaller. Although I tell patients with intertrope fractures that the long-term results are not quite as good as they are with arthroplasty. So even though the surgery is smaller, I tell people, bring them down a notch in terms of walking. If they're a good walker, they tend to need a cane.
Right.
If they're a cane, they tend to need a walker.
Yeah, that's exactly what I think of too. So there's also some breaks around the pelvis. One of the breaks that we see pretty commonly, if you could just comment on it real quick, would be a pelvic fracture, like around, if you look on a skeleton, a Halloween skeleton or whatever, those two little circles down at the bottom where it looks like it's hollow, those are the pubic rami. One of them we sit on, one of them is the front of our pelvis, and you can have a crack in that bone. Can you tell us about how that's treated?
Yeah, most of those are treated non-operatively, and mainly because it's not an area where our body bears weight. Although they're extremely painful, and for a few months while the fracture's healing and those muscles, every time you step, those muscles fire and cause pain. So it's something we treat non-operatively, although it still takes a few months to heal enough for them to feel good.
So you treat them supportively and then have them use a walker or something?
Most people need a walker for 6 to 8 weeks.
Do you let them put whatever weight feels comfortable?
Yeah, I try to tell people to do partial, although really with those types of fractures they can put as much weight on it as they're comfortable and they still heal.
Okay. Some other sundry things that might be interesting, spine compression fractures. What have you heard? I mean, we don't deal with those much. We have great spine surgeon partners so we can ask for that, but what have you heard about sticking, inflating the compression fracture or putting cement in it and things like that? Is that something that people do still?
I've certainly seen patients that have had it done and seen some good results with doing that, although I think the indications for it are narrow. So I definitely, it's one of those things I direct patients to people that do them and decide with them whether to do them or not.
So, I mean, they can fall on their butt or something and have this compressed down, or even just standing there, they can have a compression fracture, have severe pain right in the middle of their back, and then we look on an x-ray and it looks like there's been a loss of height, and that's, can see some people where they're doubled over from this, having multiple levels of compression, and so that is something that we see, and sometimes our spine colleagues will recommend a brace or something, or less and less, I think, those vertebroplasty and kyphoplasties, it seems like to me.
Yeah, I think there was a large number of them done when they first came out.
Yeah.
I think the numbers are decreasing, although I think still for the right indications it can work very well.
Good. Kind of along the same lines but separate, can you tell us if you're on an anti-inflammatory, can that have any results with bone healing? You know what I mean? Like a fracture healing?
Generally, I think anti-inflammatories can affect bone healing. It seems to be more crucial in the spine.
Right.
It seems like the spine is an area where anti-inflammatories can inhibit healing. Generally long bones, they tend to heal pretty well.
So if you have somebody who has a long bone, like an arm bone fracture, one of these proximal humerus fractures, you're okay with them, and obviously they can take Tylenol, but they can take some ibuprofen and things like that too.
Yeah, I do. It's such a vascular bone, and it's the reason that it hurts so much.
Yeah.
But it also, that same vascularity helps it heal.
Good. One thing there's been some papers recently out of Europe, mainly Canada, some where they've used less and less narcotic or opiate pain medicines for fractures, and that's one thing I've been talking to my patients a lot about is we need less of that because they can constipate you. The U.S. had 5% of the world's population and used to consume 95% of the world's hydrocodone, and so that's something where I have hard times because everyone thinks when you break a bone you have to have narcotics and things like that, but I think the Tylenol and ibuprofen and ice and meditation and stuff can be helpful.
Yeah, it's anybody that's suffered fractures, I mean, it hurts. The first few days are by far the worst.
Yeah.
Certainly pain pills play a role in trying to get people, into a home situation rather than the hospital. But it's something, that they are inherently dangerous. It's something you don't want to take chronically if you can avoid it.
Yeah.
And there certainly for the elderly population, there's a lot of side effects to taking them.
Yeah. Even the ones that are milder, like tramadol is one that I use sometimes because it's a little less addictive and things like that. But that can really throw an elderly person off sometimes and give them hallucinations and things like that, I've found. So
yeah, it seems like some patients are really sensitive to narcotics, and most of those patients would really rather have nothing.
Yeah, right. So I know we do tell our patients that weight-bearing exercise helps with osteoporosis, right? And you want to check in with your family doctor about your bone health, especially if you're after menopause, you're female. It can happen. I mean, men can get osteoporosis too, of course, but it's more common in women. Well, maybe one of the last things I want to ask you about is when do you use if ever, do you ever use a bone stimulator? It's a device to maybe make bone heal faster.
Yeah, generally, bone stimulators have a role more in fracture care than like preventative measures for people with osteoporosis. What they've learned is that bone heals better under an electrical field. So there's a number of devices that we use for fractures that are just stubborn and don't want to heal. I've had pretty good luck. I don't use a lot of them, but if somebody has a fracture that's not healing over 3-4 months, I mean, generally I'll use them. A lot of times they work. I don't know if it's the device or me just forcing me to wait longer, but they do. But they can be very successful.
Yeah, well, I think, like you said, there are some stubborn bones that, despite immobilization, certain areas like the scaphoid bone, the tibia bones, there's some that won't heal, and that can be
luckily most of the fragility fractures occur in areas that are highly vascular, and so they do heal, but areas in the hip and things like that where they become so displaced and the blood flow is so disrupted, you do end up having to do joint replacements. But for the vast majority of wrist fractures and proximal humeruses, they do heal without surgery.
Well, I can say I really learned a lot today, and I think that our audience learned a lot. And we're really happy that you're down here with us in Des Moines, and
we've really liked it.
Appreciate you coming on the show.
Yep, thanks a lot, Barron.
Thanks for listening to Joint Effort, a podcast from Des Moines Orthopedic Surgeons. If you have questions about this podcast and wish to schedule an appointment with a surgeon, call 515-224-1414 or visit DMOS.com.